is left to me to wind up this meeting. And what I'm going to try and do is to have you understand the current role of the fecal microbiota transplant for a refractory C. difficile infection, appreciate what other conditions might be amenable to treatment by FMT, but are not yet ready for widespread acceptance, and understand concerns about the robustness of data and evaluation of the safety of FMT for clinical application. We've had a lot of talk about prebiotics and probiotics, so I'm not going to cover those again, but many of the comments that I will make actually apply to the robustness of data as far as prebiotics and probiotics are concerned. Now, we've heard from John Marshall about C. difficile. This is a serious disease, and the real issue that is a challenge to us are recurrent infections. And up to a quarter of patients who have C. difficile will in fact relapse. And when we start to look at the older population, about half of the population who have a CDI who are age 65 or over actually relapse. And of course, they're people who often have comorbidities and are therefore at much greater risk. So this is an increasing clinical problem, as we all know, and there are increasing numbers of infections being reported. And we're also seeing more cases of the hypervirulent strains of C. diff, 027 and 078. And this is actually presenting quite a dilemma because a number of these patients are not responding to repeat courses of antibiotics. And in the United States, the cost is considerable, more than $3 billion a year. And you've heard that dysbiosis is common. There are changes in the composition of the intestinal microbiota in patients with recurrent CDI, and there's a reduced number of different bacterial species. So the richness of diversity is changing in an adverse way. And this has offered the opportunity for a therapeutic paradigm shift where antibiotic therapy leads to alteration of colonic microflora. C. diff then exposure leads perhaps to colonization, toxin release, and serious disease, which is then treated with antibiotics. And the alternative here has been the introduction of fecal microbiota transplant as a therapeutic aim. Now, how can we set this in some context? We've had discussions today already about the fact that the potential for stool, and coprophagia is well recognized, for example, in laboratory rats. Many people have resorted to all sorts of amazing methods to stop their dogs from eating poop. And recently, zoologists working with African elephants have noticed that they tend to have a predilection for eating poop. And in fact, they have various innovative ways with the trunk to be able to obtain stool from each other. Now, what has been shown is that young elephants do not actually have the appropriate bacterial population in their intestine to be able to properly digest twigs and leaves and bits of tree trunk and bark and so on, which is the staple diet. And so this is thought to be a primary protective mechanism for their survival to ensure that they achieve the level of diversity. And as John has already told us, the actual transfer of intestinal microbiota goes back a long way in terms of the European literature to the 17th century. And here, this was the transfer of bacteria from ruminants to ruminants that were not ruminating correctly. And this was very effective. And as John also pointed out, the Chinese have recorded evidence of transfer, at least, of intestinal bacteria going back to the 4th century. The first description in humans was actually published in 1958. And while I was a resident in the early 70s, there was a letter in the Lancet from a physician with ulcerative colitis in the Midwest who actually had a seriously refractory colitis, and he took it into his own hands, as it were, treated himself with an antibiotic, and then inoculated his rectum with his brother's stool, and a year later had had no flare. So there have been a whole host of anecdotal cases, even in the last 50 years or so. So what this process now is defined as is the infusion of a fecal suspension from a healthy individual into the GI tract of an individual with intestinal disease, with the restoration of altered intestinal microbiota by the application of bacteria from the intestine of a healthy subject. So one of the big and important issues is, who should donors be? And there's quite a debate that has gone on as to whether this should be a family member or whether this should be somebody who's anonymous. And probably many of you in the audience who might be contemplating the need for a stool transplant might prefer to actually have it from a family member. But they're hugely difficult ethical issues in terms of ensuring that that family member is socially well behaved and isn't putting themselves out a bit and at risk of carrying serious diseases, particularly things like hepatitis B, hepatitis C, syphilis, or even indeed HIV. And so there are big concerns about how we actually standardize the donors, and in fact, even with the anonymous donors, whether we actually screen them effectively every time that they're actually donating. And of course, we need to ensure that the stool doesn't have any evidence of pathogenic bacteria, particularly C. difficile, that we check that there are no ovarian parasites, and at least no norovirus, which is one of the few, together with perhaps CMV, that we are actually able to detect. Now, there are important protocols for FMT, and they vary. And one of the difficulties when we read the literature is almost everybody who's doing this has a different protocol to everybody else. They're small variations, but they can in fact potentially make a considerable difference. Certainly, the stool needs to be fresh, and the usual period is a period of 6 hours. Occasionally, people have frozen stool and use frozen stool. When we look at the literature, there's a high variability in terms of how the stool has been homogenized and mixed, for example, with saline or water, and whether it's been in 100 mils or 500 mils. Again, little or no standardization. And even the route of administration is variable. Sometimes it's been given by a nasogastric tube, usually by a nasoduodenal tube. It's been done by many people performing this through the biopsy channel of a colonoscope inserted to the cecum, but it's also been widely used by retention enema, which is infinitely more convenient, much cheaper, and the patient who's going through all of this fandangle is much happier to have the enema than they are to have to go through a colonoscopy. But you can see that there are certain implications here. You're not getting the same effect, or you are likely perhaps not to be getting the same effect if you're delivering the stool at such different sites. And therefore, how reasonable is it when we read the literature to talk about FMT producing the same results? Now, we've got a number of studies, and in fact, John Marshall didn't show his own paper, but here's one from the Archives of Internal Medicine that was published last year from the group at McMaster, which showed in 27 individuals with an average age of 70, that patients who'd had metronidazole or vancomycin for a prolonged period of time with the C. difficile infection for more than 156 days, that there was clinical resolution in 25 of 27. That's over 90%. And the follow-up here was 427 days without any relapse. So this kind of result is very encouraging, but it is still a small number, and we do need to look at the other issues. Now, one of the problems is that many of the reports don't include numbers as big as that. There are a large number of individual case reports and some studies that have only looked at 2 or 3 patients. There are a whole number of other problems that we have to take into account if we really want to make evidence-based decisions and develop evidence-based strategies. There are problems with the definitions. For example, relapse and recurrence don't necessarily mean the same thing, and they don't all necessarily, in their studies, define the end of diarrhea. The geographical possibilities of geographical differences. Some of the studies have included inpatients and outpatients at the same time. Most of them have had different protocols with respect to the way that the stool is prepared, the delivery, as I've said, upper GI tract or into the colon by colonoscope or enema, whether it's fresh or frozen samples. Most of them have had relatively short follow-up. And it's clearly most important that we consider safety in a longer term. You only have to consider blood transfusion and the potential risks that can occur with blood transfusion. And here in Canada, the horrendous disaster when people develop hepatitis C. So we do need to bear in mind that when we're dealing with body fluids, that we have to be extremely careful. There is a lack of randomized controlled trials and limitations in previous systematic reviews, which have included case reports and abstracts. We then decided to do a systematic review with robust methods to determine the efficacy and safety in this indication of C. difficile infection. And we planned sub-analyses to explore both the quality of the studies and whether there was a difference in the outcome in quality, high quality versus low quality studies, the mode of stool delivery, upper versus lower, and whether family member or anonymous donor made a difference. But I want to emphasize how difficult it is to judge success and failure objectively when randomized controlled trials are not available. And in this situation, there is only one, and that actually was published during the time that we were, when we just completed our meta-analysis. And one of the difficulties, this is an area where you can't do a randomized blinded controlled trial. And we know what the hazards of that are. There are plenty of examples in the literature of how wrong our interpretations can be. So we set out to look at FMT by any delivery modality with laboratory or endoscopic confirmation of C. difficile infection and of clinical diarrhea. We only took a case series of more than 10 patients, and the primary outcome measure we took was clinical resolution of diarrhea, not necessarily evidence of cure of C. diff infection. We looked at the Center for Reviews and Dissemination and NICE methods to assess the quality of the studies, and there were 2,709 studies that were identified with our initial search, 30 of which met the criteria for our full evaluation, and overall 11 studies involving only 273 patients finally met the criteria. They came from the US, Canada, the UK, Finland, Czech Republic, Norway, and Sweden. There were mixed patients in patients and ambulatory patients in 6 of the 11 studies. 2 were outpatients only, and 1 had inpatients only, and 2 didn't report even where their patients had come from. Mean age was over 65 in 8 of the 11 studies, and 65% of cases were female. What was disappointing was the comorbidities were not specified in the majority of these studies. They didn't mention whether they had IBD or IBS in addition to their C. diff. And of course, C. diff is an important complication in patients with inflammatory bowel disease. The acquisition of their C. diff was not reported in the majority of studies, and only 1 reported whether in fact there was a virulent strain. In terms of the type of infection, it was recurrent in 6, recurrent and refractory in 4, and unclear in 1. So, you know, as we try to synthesize this information, it starts to be very difficult to consider them all as a homogeneous data set. It's like comparing apples and oranges. The donor was patient selected in 7, anonymous in 2, and both in 2 of the trials where people were treated more than once. The stool was fresh in 10 of the studies and frozen in 1. Delivery was by colonoscopy only in 5, by nasogastric or nasojejunal tube in 3, colonoscopy and a gastrostomy in 1, colonoscopy and an upper GI endoscopy in 1, and by enema in 1. So hugely different variation. And here you can see, take a quick look at it, but you'll see the stool sample in terms of the weight of stool and the volume of the solution, highly variable, wasn't standardized across any of those studies. So what was the result of the meta-analysis? Well, it was quite remarkable, because you'll see that 245 of the 273 patients experienced clinical resolution. The unweighted and weighted, and I won't go into the details of how that was done, were virtually identical, 89.7 and 89.1% resolution, no meaningful difference between them. So a remarkably good result. And at about that time, when we were at that point in the analysis, the paper which John Marshall has already shown us today was published in the New England Journal, and you can see here on the left the first infusion of donor feces, and then the infusion of feces overall, the result of vancomycin, and then vancomycin where bowel lavage was done. And you'll see that both the columns showing first infusion or overall infusion gave really remarkably good results in these 12 individuals. Now again, this was randomized, but of course it wasn't blinded. But it was particularly encouraging that a study that had attempted to control for a variety of the parameters was confirming these overall good results. And indeed, they did look at the diversity of the bacterial population, which you'll see in the middle there, the patients before the infusion and 14 days after they had their FMT, shown in the box on the right, clearly restoring them at that point to a comparable level to that of the donor analysis. When we looked at the study quality, the higher quality studies, of which there were 7, is shown in the upper boxes, and the lower quality, that's nice scores less than 4, of which there were 4 studies, you'll see that there was in fact a difference in the unweighted rate. It was 93.5% in the high quality studies and 81.8% in the poor quality studies, and that was mirrored when we looked at the weighted rates, and so this was giving us a proportional difference of around 12% in respect of the high quality studies versus the poor quality studies. And there's an important message in this, because there are a lot of poor quality studies that are out there with respect to not only FMT but probiotic studies and prebiotic studies as well. When we looked at the mode of delivery, whether it was upper GI tract, colonoscopy, or retention enema, you can see similarly here for lower GI delivery versus upper, 91.4 versus 82.3, and weighted 91.2 to 80.6. This is interesting because these results are not, in fact, or are only just at the level of significance, but suggest that there is a 9 or 10% advantage to delivery to the lower GI tract as opposed to via the upper GI tract. And intuitively, I think most of us, for this condition at least, would say that that was probably likely what we expect. The numbers here are not great, and therefore this is marginal, but I think there is no evidence yet as to whether there is an advantage of enema over colonoscopy. In this situation, we looked at colonoscopy and enema together. And as far as the anonymous versus the family donor, you see the upper block, the patient selected partner, and you'll see that there's no difference there for the unweighted, 89% with 90%, and once weighted, 89 and 89, no difference here. And that's encouraging in terms of the current situation regarding selection of the donors. The adverse events, as reported in these studies, and I should point out that they were not designed particularly to look for adverse events, and therefore relied essentially on any kind of event that was reported rather than on an objective questionnaire. But the majority of studies did not report any adverse events related to the FMT, 8 out of 11. 3 studies in the upper GI delivery had at least a theoretical association with the intubation procedures. There was 1 upper GI bleed, 1 case of peritonitis, and 1 case of enteritis, which may or may not have been related. But again, there was the highly variable follow-up. Some studies had only followed for 3 weeks, although 1 study had gone out to 8 years. So what do we see looking ahead? Well, here's old W, and as you can see, he's still got the caps on the lens. So whether he thought he was like Nelson, who put his telescope intentionally to his blind eye, one actually doubts, because he was not much of a student of history. But as we've heard today in the discussions from our colleagues, there are other possible indications, including ulcerative colitis and Crohn's disease, IBS, constipation, metabolic syndrome, multiple sclerosis, idiopathic thrombocytopenic purpura, Parkinson's disease. There are many possibilities that have been advocated, and some of which our colleagues have discussed today. In terms of ulcerative colitis, there are quite a number of studies that are out there, and you'll see the results are good, but the numbers are incredibly small. 6 of 6 patients by Tom Barodi in Australia, 92% response and 68% remission in an abstract that he published some 9 years later. Dr. Larry Brandt, who we've heard mentioned before, from Montefiore in New York, response 6 out of 6 and remission, however, in 2 out of 6, and so on. These are very small numbers. Fortunately, now there are randomized prospective studies that are underway, including one that's being run by John Marshall, Paul Moetti, and colleagues at McMaster. We've also heard this mentioned, I think, by Richard Fedorak in his talk, that there is this intriguing study that was published very recently looking at the potential role of FMT in metabolic syndrome, and where, as he in fact showed us, there was an increase in insulin sensitivity, both peripheral insulin sensitivity as well as hepatic insulin sensitivity 6 weeks after FMT. This is really a phenomenon that we're seeing reported here, and exactly what it means and what the implications are remains for further research. And of course, a really important point, especially as everybody was somewhat horrified when we started talking about stool transplantation earlier in the afternoon, is does it actually have to be a human stool? And this is the exciting study from Elaine Petrov and colleagues at Queen's in Kingston, looking at the development of a stool substitute to which a panoply of the appropriate bacteria have been added. And they very nicely suggested this was repopulating the microbiota of the gut. And this, I think, is a hugely important step forward to being able to start the kind of engineering with the microbiome, which has been addressed in part by Steve Collins and others today. But there's also this concern that FMT is being oversold. There are books on fecal transplant, I mean, even the Fecal Transplant Guidebook, the FMT Coach. The media has got hold of this, and even the Scientific American has leapt on the bandwagon. The FDA attempted earlier this year to say that no physician in the US should carry out FMT without filing an IND. Which is a huge expectation, and they had to eat their words and have backed off on that particular demand, but the regulatory processes are still of considerable concern. And then there are the strong believers and the advocates that this should be done for anybody and everybody who's got any kind of problem. And a few people, and I count myself as close to this, that we need to slow down, make sure that we have the right evidence, because it isn't complete. And of course, the reason is it's a bit like poor old Donald Rumsfeld and his known knowns and his known unknowns and the unknown unknowns, because there are clearly unknown unknowns that we have to seriously take into account here. And the potential risks are real. Transmission of communicable disease or unknown pathogens remains a reality. And I'm standing here and started my training before hepatitis B was discovered by Barack Bloomberg. I've also stand here in the full knowledge of the impact that transmission of hepatitis C had on blood transfusion services and on many Canadians. So we mustn't be smug. We've got to be extremely responsible, and the better the science we do, the better protected are the patients who are going to benefit from this. And remember that the microbiota includes a virome and a fungome. It includes phages as well as the bacteria that we've talked about today. Donor screening varies widely, and we don't know how often we should screen our universal donors. And it's quite possible that activation of unintended processes may occur in the host. And we've talked about some of those today. Autoimmune disease, IBD, depression. People may, in fact, have changes in personality after stool transplant. I mean, nobody has bothered to measure those yet, but from everything Steve Collins told us, we do need to be aware of these things. But the benefits are quite clear. This is a new therapeutic option, which I think is quite clear for people with C. difficile infection, which is either refractory or recurring frequently. We do not have effective therapy for that, and therefore stool transplant under controlled conditions is a very good way to go. And really, at the moment, we are fortunate that we've had few side effects reported. And some of these transplants have been done in seriously sick patients. And so we could almost consider that some of these procedures have had less side effects than people who've had repeated vancomycin or fidaxomicin or any of the other antibiotics. So in the future, I think we need to clarify indications. We need to be quite clear in C. diff whether we stick to recurrent or refractory disease or whether it's used earlier. We do need to do proper, formal, prospective, controlled studies in IBD, IBS, constipation, diabetes, obesity, MS, and so on. We need to have standardized donor screening. We need to standardize the route and means of the administration. We need to be very aware of the safety implications in terms of infections, food and drug allergies, which may be aggravated, and standardize all of those protocols. We probably ought to have treatment registries because we do not have good ways for assessing long-term follow-up. And we need to look at the whole issue of the bacterial specificity, whether we can find the key bacteria that are important in this, so that we only actually have to administer the key bacteria that is linked to the disease in question. And of course, the artificial stool or stool capsules, which are under investigation, are also there on the horizon for us. So thank you for your attention, and I'll be happy to take questions in the discussion.